ASCEND-4 was designed to compare ceritinib versus chemotherapy in the first-line setting. Really a very rational design. It was taking patients with newly diagnosed advanced non-small cell lung cancer who had ALK-rearranged cancers, and they were randomized to either chemotherapy, a platinum doublet, or to ceritinib alone. The trial met its overall endpoint. It improved progression-free survival for patients who received ceritinib compared with chemotherapy. And this trial has moved ceritinib from a second-line setting into the first-line setting as a new standard of care for patients with ALK-rearranged lung cancer. Ceritinib is a fantastic drug. It's very effective in treating ALK-rearranged lung cancer. It's effective at penetrating the CNS and helping treat patients with brain metastases as well. One challenge for ceritinib use has been toxicity, namely gastrointestinal toxicity. We use ceritinib at the approved dose of 750 milligrams a day, but often have to reduce the drug to make it a more tolerable drug for patients because of that GI toxicity. Often we will have patients dose this away from food. That's the approval, is to not take it with food. Food increases the absorption. And so lowering the dose from 750 to 600 is a common strategy, and then even going to as low as 450 milligrams a day. There are other tricks too. We try dosing this at nighttime and sometimes use antiemetics prior to dosing with the therapy. But there are recent data that suggest taking ceritinib at a lower dose with food, a low-fat meal, can obtain serum concentrations that are equivalent to the full dosing and hopefully minimize toxicity. And although this hasn't gotten into the label, I think this is a strategy that hopefully one day could get into the label, or at least be how patients use this drug. So instead of giving the drug at 750 milligrams a day without food, if you took it with a low-fat meal at 450 milligrams a day, you can achieve the same serum concentrations. And in theory, that could hopefully maintain efficacy and perhaps reduce toxicity as well. The original trials were not designed to look at that dose with food. So the published data that we have, the registration data, use the 750 milligram dose. It's important to emphasize. This may be an alternate strategy as we learn over time that this looks to be as good from an efficacy standpoint and maybe safer for patients. But more there to show, but at least potentially an alternate strategy to help patients stay on this drug longer. The 450 milligram dose with food looks to be equivalent from a pharmacokinetic profile to the 750 milligram fasted dosing. So again, the 750 milligram dosing is the FDA approved dose in label fasting, but these new data suggest that a 450 milligram dose with a low-fat diet, a low-fat meal, I should say, achieves the same pharmacokinetic profile that the approved dose has, and hopefully that would lead to a better safety profile for patients. More prospective data would be ideal here, but dose reductions are common in routine use now in the community setting, and learning more about how food could actually improve the efficacy and maintain safety is an important step forward in ceritinib's use. So I think these data are very important. It's a small study and may one day, with confirmatory data, expand its label and at least help patients and doctors better manage some of the toxicity they're experiencing. Gastrointestinal toxicity is one of the main toxicities of ceritinib, and there are different strategies we use to help mitigate that. The most common is simply lowering the dose, so starting at 750 milligrams in a fasting state and then lowering to 600 and sometimes to 450. It can be an effective strategy. There are other effective strategies too that can include nighttime dosing, so having the patients dose this before they go to sleep is one way to make this a more tolerable therapy from a GI perspective. The other is the use of antiemetics. I tend to use antiemetics pretty frequently as a pre-dose with this. A lot of my colleagues don't do that, but I find this to be an effective strategy. So taking an antiemetic such as ondansetron or granisetron can make this a more tolerable regimen for patients. But everyone's different. You have to kind of adjust things at a patient level to see what works. But there are at least a few things you can try. And then, again, some earlier data that suggests taking with a low-fat meal at a lower dose, 450 milligrams, can achieve the same serum pharmacokinetic parameters and hopefully make this a more tolerable regimen for patients. Ceritinib is a fantastic drug. I remember when it was first presented, it was standing room only, a major breakthrough for patients, a drug that helps not only patients who've never received crizotinib, but patients who've been through crizotinib. The experience with ceritinib has been that it's helped a lot of patients do well for not just a short period of time. There are some patients who can do well for years. In fact, my first patient on ceritinib as part of a clinical trial had remained on therapy for over 3 years with excellent control, and even with the development of brain metastases prior to going on to the drug, the patient remained asymptomatic and remained on therapy with good control of that lesion for years. This is a drug that has to be adjusted in most patients. It's very unusual. You can stay at the full dose and schedule, and so like with a lot of oral therapies we use, we make adjustments and patients can do very well. It is a very effective therapy, and fortunately we have several effective therapies in this setting for patients with ALK-rearranged lung cancer, and even more on the horizon. But this is one of those that has helped a lot of patients.